I've been in the healthcare interpreting field for 25 years, and I would say that the profession chose me first, maybe just as a destiny kind of concept, and then I've actively loved it. I was in Portland, Oregon in 1994, and it was a bit of serendipity. I had a coworker from a restaurant that I was working at after I graduated from university who had asked me to come with him to a doctor's appointment. And because he didn't speak very much English, and the doctor wasn't going to speak any Spanish, and I had helped with interpreting at the restaurant many times. The management would come to me and say, "Andrea, can you help? We're trying to help someone understand something, or help these two colleagues work together and understand each other." And so he knew I spoke Spanish, and so I went with him. I said, "Sure," and it was really close to the hospital. It wasn't much of a commitment on my part, and I didn't mind helping. And afterwards, I thought, "Goodness, he got what he needed." He was so happy. The doctor seemed satisfied. I don't really remember very many specifics. I just remember a tremendous feeling of enjoyment and satisfaction, and realizing I could marry or unite two things that I loved dearly, which was the field of medicine and the Spanish language and the Latin American culture. And so I started calling around. It was 1994, so this was before cell phones. This was before widespread access to the internet. We had the yellow pages and the white pages back then. And so I made a bunch of calls, and I ended up finding out about Pacific Interpreters. They were a very small company at the time, and the field was just really starting to gain some traction in the Pacific Northwest with Cindy Rote and Bridging the Gap and the cross-cultural healthcare program, and it was just starting to get disseminated. And that's how my story began, and I have loved it ever since. I love it more now than I loved it then. Uh, Definitely more focus on decision-making skills for interpreters, and advanced practice strategies for interpreters, so that we can make a bigger impact in the encounter for both the patient and the caregivers and the providers. I follow a lot on Facebook. There's several medical interpreting groups that I've learned quite a bit from. Everybody shares their different circumstances, things they've done. They want feedback on their practice decisions, on vocabulary. You could get on Facebook and find a lot of different groups for medical or healthcare interpreters. So I follow those, and I also am on the NCIHC listserv, and that's tremendously useful for me. And I also am on LinkedIn, and I've lately been a little bit more active on Twitter. I would definitely say two of my favorite books are, and one it's been like almost like a Bible, not to be sacrilegious, but something that I read regularly when I just feel like being inspired. This is the older book, and I'll give you a newer one in a minute. The Brain That Changes Itself by Dr. Deutsch. It's a wonderful book about neuroplasticity. And because I work in healthcare, and because we do work with children, I work in a children's hospital. There are times where they're dealing with neurological issues, and certainly with trauma, the concern that they've lost some amount of brain capacity. So this book was wonderful because it taught me a lot about the ability by the brain to change itself despite what we used to think. So it's really inspiring if you do work with patients that have been in any kind of traumatic accident, or have had a stroke, or any kind of cerebral or neurological insult. It's wonderful because you learn a lot, and it also inspires you, and makes those kinds of encounters a little less difficult, because you realize there's a lot of hope and there's a lot of things we can do these days. And then my newest book that I would recommend, that I absolutely love, is also healthcare related. It's on the immune system. It's called An Elegant Defense by Richter, Richter. He's also a journalist like you. And it's a wonderful book about the immune system and the research that's been done for decades and decades, and how long it's taken to understand how to manipulate the immune system so that we can save people from devastating diseases like cancer and HIV and autoimmune diseases. It's really relatable. It's a book that even if you're not aware of anything about the immune system, but you're curious, you can actually read it comfortably because it's written in a way that's very easy to read. He wrote it through four, there's four people that he focused on with different diseases, and so it's their story, and then he interweaves all the research that's been done and things that they've understood about the immune system, and as they've gotten closer to making sense of it, they've created incredible treatments. And so it's also quite hopeful, and it's really useful because this vocabulary, you need to understand it to be able to interpret it. We really do need to understand everything that comes in. The input is you have to understand it in order for your output to be accurate. So it helps me as an interpreter. For healthcare interpreters, which I do believe is probably different in terms of what I would recommend, because legal interpreting and conference interpreting have a similar requirement for accuracy, of course, and for being able to toggle between two languages and have a really good memory and short-term memory retention. But for healthcare interpreters, because the healthcare environment is collaborative and is so focused on both sides winning, I think it's entirely necessary for us to have emotional intelligence so that we can negotiate in the encounter effectively and navigate the sometimes kind of tricky interpersonal aspect of the encounter. And we should always be developing it and understanding and reflecting on how our decisions affected the parties in the encounter and whether or not we were an instrumental part of the success of the encounter. Because success in the encounter is a positive outcome for that patient, and everybody wants that in healthcare. That's not the same in legal. If you think about legal, there's always a winner and a loser. In healthcare, it's everybody wins when the patient does well. So I think for an interpreter to understand who they are and how they manage conflict, how they negotiate really complicated differences between the provider and the patient, and what they do to intervene when they need to, how they manage that and reflect upon it. Like all of those things, I think make us terrific members of the healthcare team. Whew. So I've been interpreting for 25 years, and I've been at Children's Healthcare for 18, and I am full time. And so I've gotten a little bit of experience to recognize when I'm really needing to address mental fatigue or prevent it. So it is sort of a self-reflection kind of process of understanding when you've hit that limit or trying to avoid that. So I first try to see mental fatigue as a logical response to the work that we do. Healthcare interpreting, I would argue, is very complex, and especially some encounters, not all. And so generally, I try to look at it as a logical thing that my gas tank might be getting low. And then I ask for what I need. So if I need 10 minutes to clear my head or recover some mental energy, I ask for it. I might ask the providers and the patients, or in my situation in a children's facility, I'll ask the parents and say, I need to step out. And I'll give them the reason, like I need to go get some water. Excuse me, I have a scratchy throat, or I'm going to go to the restroom real quick. Sometimes in a very long encounter, I know I'm going to need at some point to step up or step out. And so, and even if I don't really need to go to the bathroom, I would recommend the bathroom as a very good place to go and clear your head. Either in a stall or in a private bathroom, you can turn the lights off if it's private and just get a little mental break so that your gas tank can be somewhat replenished and so that you can go back and continue performing at an optimal level. I think we could all agree that when we're really mentally fatigued from a really complex encounter, not necessarily a long encounter, but a complex one that maybe goes longer than you've got the ability to manage it, we would start probably struggling to stay accurate and to do the best for that patient. And so I might ask the dispatcher as well if it's possible to get a few minutes, either right in the middle of the encounter, if it's been going on for hours, or after the encounter, and just explain that my energy tank is at empty. And in order to do my best performance, I need a little bit of a break. And I ask for it. That doesn't necessarily mean we get it. A lot of facilities struggle to manage the requests and staffing. So I understand that even though I ask it, I may not always get it, but I do recommend that interpreters absolutely ask for it. That's the beginning of us eventually getting to a point where we've got better standards in the field. We have to make our needs known. And then sometimes I look for a chair. I bring my own into the room. Several of us at Children's Healthcare of Atlanta at different points in our career there have had our own little foldable stool or a tiny little chair that we would carry with us. Now I'm at the point where I've just learned that I can usually find a chair out in the hallway, and I'll say, "Oh, excuse me, I'm going to go grab a chair. I'm very tall. I don't want you to strain to look up at me, especially if the parents are sitting." That's a nice way to have them understand that. Or sometimes I just say something a little bit more direct, like, "Oh, I concentrate so much better when I'm sitting." And I can take notes a little bit more effectively also when I'm sitting. So I try to give them the why. Um, and then also, I think just sometimes uh, we might have our own unique ways of handling it. So there's probably a lot more strategies than the ones I just gave. But those are my first line of defense. That's a good question. We don't require it where I work, but we do prefer it. So applicants who come on board, it's a preferred qualification. So it's definitely viewed as something, that at least corroborates somebody's skill set at a very basic preliminary level. Of course, all these other things like interpersonal skills and emotional intelligence are also things that they interview for. I would say that a large percentage of us are credentialed at Children's Healthcare of Atlanta. There's about 35 interpreters, and a large amount of those are credentialed with either CMI or CHI, or both. But we don't require it. So I'm not sure if we would get to that point where we require it. But I do think that it's a good thing, and our field has made great strides to get this far. Yes, we've been asked by the legal interpreting community as well as the educational interpreting community about adapting the tool to those settings and those particular types of interpreting. And we would definitely love to be able to do that. Adaptation does require several steps, but if this process that we're in right now, once we complete it and the tool is accessible, or if the healthcare interpreting field can start using it, then after that point, we would start looking at adapting it and have to take it one step at a time. And it would require that uh, people do focus groups and other ways to gather information, like maybe anonymous surveys, to understand some of the unique aspects of educational interpreting versus legal interpreting, things that might be different than healthcare interpreting in terms of the factors that we're measuring on the tool or the demands that we're measuring. So there might be some differences. So we would have to go through that process, but absolutely it would be wonderful to be able to adapt it, and if it were useful for those other fields in interpreting, it would be great. So inter-rater reliability it's a term to describe the process of assessing or evaluating whether or not a newly developed tool will yield the same results regardless of who uses it. So regardless of rater. Rater is just another way to describe the person who's actually using it. So one example would be that one interpreter is interpreting during a particular encounter and certain demands come up. And if the other interpreter in the exact same encounter uses the tool in the exact same way with the same results, independent of one another, that would be that's essentially what you're looking at when you're doing inter-rater reliability. You're looking to see if the tool is reliable, and that essentially means that two raters will use it the same way. in the same encounter. It was done with just face-to-face in the phase 1 and phase 2. So we had 24 interpreters at Children's Healthcare of Atlanta total, 7 for the first phase and 17 for the second phase. And in both of those phases of data collection using the tool as part of the research, uh, they only used it for face-to-face. That was part of the study design, that it was not going to be used for phone interpreting. And we don't do VRI at Children's Healthcare of Atlanta, so that wasn't an option then. Now that we're in the external phase, which is that we are testing the tool out at 3 different facilities, Cambridge Health Alliance in Boston, they've already completed their 3 months and generated a lot of data, more data than we've ever had. They used it for all 3 modalities, so face-to-face, OPI, and VRI. They've completed their 3 months, and now Cincinnati Children's, who's also using it, there's 11 interpreters there using it for all 3 modalities. And then University Health System San Antonio is also using the tool right now for all 3 modalities. And they're both those other 2 hospitals are getting close to completing their 3 months of data collection. And there's about uh, 10 different language pairs within all 3 of those facilities. So I work at Eggleston, which is one of Children's Healthcare of Atlanta's facilities. It's the level 1 trauma center, and it's also a teaching facility. And I mention that because there are really complicated cases, like open heart surgery for kids with defects, and sometimes a series of operations for certain types of diagnoses and cardiopathologies. And then we also do bone marrow transplants, immunotherapy, research, research studies that patients can enroll in. And then we also have uh, all kinds of different cancer treatments and long family conferences for updating the family or discussing how things are going, and those can be quite long. So because of the nature of a level 1 trauma center and a teaching facility, some of those cases are so complicated that the encounters can be quite long. And so I would say that maybe on average, the longest one every so often for each of us might be around the 2-hour mark. We have a wonderful dispatching system and a really well fleshed out leadership, and they are quite supportive of us not going beyond where we think we can go in order to be accurate and perform effectively. So they will usually check in with us because it's hard to know. In research, they've shown that interpreters are not necessarily aware when they're making mistakes from fatigue. Sometimes, I think in one of the studies with conference interpreting, you don't necessarily notice that you've been making mistakes till you've been making them for about 30 minutes. That was, of course, in conference interpreting, and it was simultaneous. But we're aware of that issue, and so we do reach out to the dispatcher sometimes when we're hitting that limit. But about 2 hours would be maybe the average every once in a while. So paralinguistic is a term to describe the way people talk, the way they communicate during the encounter, and essentially refers to what we as interpreters have to attend to and how we navigate those kinds of demands in terms of how people talk while we're trying to focus on our primary task, which is to interpret the dialogue effectively and accurately. So things that come up while we're trying to interpret effectively and accurately might be that one of the parties has a very strong accent that is making it hard for us to get accurate input enough to yield accurate output. And so that might be something we have to navigate and work with. They might be a mumbler or a low talker, or they might whisper. So that's one of the paralinguistic demands, for an example. And then sensory refers to the environment in which the interpreter must work or must perform our primary task. So sensory issues might include noise or any auditory distraction that we need to sublimate or try to ignore for the sake of concentration in a healthcare environment.